Everyone. Today's topic of discussion is nutritional deficiencies in squamous cell carcinoma and cancer cachexia. From introduction, head and neck cancers are malignant tumor of upper aerodigestive tract, including oral cavity, nasopharynx, oropharynx, and hypopharynx and larynx. Among all etiological factors, smoking and chewing of tobacco are considered important for development of head and neck cancers. About 25 to 50% of head and neck cancer patients are found nutritionally compromised prior to the commencement of the treatment only. Poor nutritional status affects their physical function, quality of life, and overall survival of the patient. A meta-analysis of literature. Yes.
Only you get from the classroom.
Yes, sir.
I think Squamous cell carcinoma is कहीं use.
Yes, sir.
We are presenting
For head and neck. A meta-analysis of literature reported that 20 to 30% of head and neck cancer patients have a significant weight loss at the time of diagnosis just before initiation of cancer treatment. In addition, up to half of the patient lose more than 5% of the weight during the treatment. Micronutrient deficiency can influence squamous cell carcinoma development and recovery. Problem with nutrition already start with the disease onset, with various studies showing 20 to 65% of head and neck cancer presenting themselves with the malnutrition, with more than 10% weight loss from the normal body mass. Chronic malnutrition, which is associated with alcohol and tobacco use, trismus, obstruction of the respiratory and the digestive system, with aspiration, odynophagia, and dysphagia. Furthermore, according to the several studies, malnutrition in head and neck cancer patient during therapy can be presented in substantially high percentage, up to 80%. Mucositis is commonly associated with chemotherapy and radiotherapy and is characterized by inflamed lesion in the area of mouth and throat. These complications are connected to infections like dysphagia and pain and among others. Xerostomia, adverse effect of the radiotherapy that significantly reduce the quality of life of the patient and are often associated with thick saliva. This causes further negative effect on chewing, swallowing, and speaking with an accompanying increase in infection. Studies have shown that weight loss before the treatment was one of the main independent survival predictor, while nutritional support before surgery can lead to significant beneficial changes in quality of life with fewer post-operative infectious complications. The identification of 2 or more of the following 6 characteristics is recommended for diagnosis of malnutrition. First, insufficient energy intake, weight loss, loss of muscle mass, loss of subcutaneous fat, localized or generalized fluid accumulation that may sometimes masked by the weight loss, diminished functional status as measured by the hand grip strength. Now, further moving towards the particular vitamin deficiency, vitamin A plays a key role in epithelial integrity and immune regulation. Its deficiency can lead to abnormal keratinization and increased risk of dysplasia. Zinc plays a crucial role for DNA repair, immunity, and wound healing. Its deficiency may impair the immune surveillance and promote oxidative damage. Selenium plays an antioxidant role via glutathione peroxidase. Its low level in the body can increase the oxidative stress. The iron, it plays a vital role in cell proliferation and DNA repair. Its deficiency is mainly associated with the Plummer-Wilson syndrome and have a high risk of esophageal cancer of squamous cell carcinoma. Folate and vitamin B12 deficiency needed for the DNA methylation and synthesis. Their deficiency can also cause genomic instability. Vitamin D modulates the cell growth and immune response. Their low level may increase the susceptibility to squamous cell carcinoma and affect the tumor immunity and prognosis. Now comes to the part of nutritional assessment, that how we will be assessing the nutritional insufficiency in the patient. Malnutrition can be referred to by following severe different criteria, including more than 5% weight loss in 3 months or more than 10% weight loss in 6-month period, or BMI less than 20 kg per meter square, while albumin level less than 35 gram per liter can be suggestive of malnutrition as well. There's a thing we have discussed BMI, how to calculate BMI? There's a metric instrument measurement in which we have taken a height of 1.75 meter. So we are keeping it the square of the height, which comes to 3.06 meters square. So now the BMI have a formula is weight upon height square. That's come to the value 24.5 kg per meter square. The oldest method used to evaluate nutritional status in comparing body weight with usual weight or ideal body weight using the Humvai formula. The man, the ideal weight is equal to 106 pound plus 6 pound for every inch over the 5 feet. Woman, ideal weight is equal to 100 pounds plus 5 pound for every inch over the 5 feet. Once the ideal body weight is determined, the patient body weight loss as percentage of ideal body weight can be determined by percentage of the weight loss is equal to ideal body weight minus admission weight upon the ideal body weight into 100. Body mass index has been found to be a useful tool to evaluate the nutritional status. A body mass index no greater than 18.5 kg per meter square is considered as underweight. Next thing, several biomechanical markers exist for testing nutritional status. Traditionally, albumin, which have a normal range of 3.5 to 4.5 gram per deciliter. Pre-albumin, normal range comes to be 200 to 260 milligram per deciliter. And transferrin, what normal range of 15 to 25 milligram per deciliter, has been used to identify the nutritional depletion. However, no single marker measures nutritional status accurately. These values with the mild, moderate, and severe have been given in the table for albumin, transferrin, and pre-albumin. Now the nutritional modalities. During the inadequate nutrition intake, patients are prone to weight loss, decrease in muscle mass, fatigue, and anemia, which can lead to cancer cachexia syndrome. Sorry for that. Studies indicate that impaired nutritional status is noticed in 25 to 27% of the patient at time of diagnosis and before the start of the treatment. Cancer treatment can further aggravate treatment related to dysphagia, resulting in the reduced food intake and deteriorating the nutritional status. Severe weight loss, more than 10% of the body weight during treatment, have been observed in the absence of intensive nutrition support in up to 58% of the patients. Oral intake of the food is the preferred method of nutrition. But in case when adequate nutritional intake cannot be maintained by the mouth, enteral and parenteral nutrition is necessary. Enteral nutrition is preferred over parenteral nutrition, being physiologically natural. It also maintains gastrointestinal integrity, protecting it from atrophy and also support gut immune function. Numerous studies have shown that administering feeding tube before the start of the treatment in patient ensures better overall outcomes. It acts beneficially in the prevention of the weight loss and sarcopenia, dehydration, reduce hospital admission, and improve quality of life. Moving to a further part of the presentation, that's the cancer cachexia. It is a multifactorial syndrome marked by ongoing loss of skeletal muscle mass with or without fat loss that cannot be fully reversed by conventional nutritional support. It leads to progressive function impairment and is distinct from general malnutrition. This condition is prevalent in advanced stage of the cancer, affecting up to 80% of the terminal cancer patients and contributing to approximately 20 to 25% of cancer-related deaths. Summarizing what is cancer cachexia, it's a multifactorial syndrome characterized by the severe body weight, fat, and muscle loss. It is not fully reversible by nutritional support. It contributes to 20 to 25% of cancer deaths. The stages of cachexia. It is pre-cachexia in which minor weight loss, inflammation, and anorexia is seen. Cachexia, more than 5% weight loss, muscle wasting, poor response to the nutrition is seen. Refractive cachexia, resistant to the treatment, life expectancy less than 3 months is seen. Causes and pathophysiology. Cancer cachexia arises for combination of factors. Metabolic alteration. Cancer increases the body energy expenditure while decreasing the appetite, leading to negative energy balance. Inflammatory cytokines, substances like tumor necrosis factor and interleukin-6 promote the muscle breakdown and interfere with the muscle regeneration. Insulin resistance, impaired insulin signaling affect glucose uptake in the muscle and exacerbating the muscle loss. Tumor-derived factor disrupt its metabolism. Signs and symptoms of cancer cachexia include involuntary weight loss, more than 5% of the body weight over 6 months, or 10% include muscle and fat loss. Muscle wasting, noticeably reduction in muscle mass, leading to weakness and fatigue. Anorexia, loss of appetite and reduced food intake. Anemia, low red blood cell count contributing to fatigue. Frequent infection due to compromised immune system. A diagnosis can be made for the cancer cachexia, like clinical history and weight monitoring should be done. Lab tests for inflammatory markers. The tool which are used are BMI, weight loss percentage, CRP is C-reactive protein, and albumin levels should be assessed. Now comes to the management approach. Currently, there is no definitive cure for cancer cachexia, but a multimodal approach can help and manage its symptoms. Nutritional support includes high protein, high calorie diet are recommended, although they may not fully reverse muscle wasting. Exercise like tailored physical activity can help maintain muscle strength and function. Psychosocial support should be given to the group by the group can assist patient and family in coping with emotional aspect of cachexia. There are some emerging treatment for the cancer cachexia. In medicinal aspect, appetite stimulants like megestrol acetate and corticosteroid can temporarily increase the appetite. Secondly, anamoreline are ghrelin receptor agonists that have shown promise in increased appetite and lean body mass. Ponsegromab, investigational monoclonal antibody targeting GDF15, currently in clinical trial, have demonstrated positive results in increasing body weight and muscle mass in cancer patients. Anti-inflammatory and anti-catabolic drugs are also used. Anabolic agent and muscle-preserving compound are used as an emerging treatment for cancer cachexia. Method of nutritional administration. Feeding tubes are placed in gastrointestinal system. Gastrostomy tube placement before radiation therapy has been shown to prevent weight loss, treatment interruption, and dehydration. In general, a nasogastric feeding tube should be used if expected length of the use is shorter than 30 days. These tubes can irritate the nasal mucosa and may not be tolerated well. There is a table which showing different types of tube according to their term for the short term and the long term. Going with enteral nutrition method, nasogastric tube and nasojejunal tube, they are used for the short term period. They have advantage like simple placement and cheap. Can be used in the patient with impaired gastric mobility, reduced aspiration risk and cheap. The disadvantage is the potential displacement and risk of aspiration. No bolus feeding can be given through that. Now comes to the second part is the gastrostomy. Percutaneous endoscopic gastrostomy and radiologically inserted gastrostomy and jejunostomy are the methods which are used for the long term when we are needing the tube for the long term period. They can be used for the long term. They are the minimally invasive technique. The disadvantage may come with that they need a sedation part. It's an invasive technique. Potential displacement and stoma complication can be seen with tumor seeding in the percutaneous endoscopic gastrostomy. In the radiologically inserted gastrostomy, it can be used for the prolonged term. It is minimally invasive and no need of sedation is taken. In the disadvantage, invasive technique, stoma complication and potential displacement due to the smaller tube is seen. Jejunostomy, it can be used for the long term with the no risk of aspiration and less discomfort. The disadvantage is bypasses the stomach, continuous slow rate of feeding and potential bowel obstruction is seen. That was the enteral feeding part. Now comes to the parenteral nutrition. When the intake of food and nutrition absorption become almost impossible due to defective, unavailable or ruptured gastrointestinal tract, parenteral nutrition is the best and the only choice. The main indication of the parenteral nutrition is when there is no other way to meet the required calorie intake. Several other indications are severe catabolic state due to severity of the patient's condition, such as sepsis and the polytrauma, gastrointestinal malformation, congenital in children and after surgery or cancer, severe vomiting and diarrhea. This type of nutrition is also recommended for terminal care patient. Parenteral nutrition is contraindicated in patient with functional gastrointestinal tract, patient that do not have access to intravenous line, and in patient that need therapy for fewer than 5 days, and if they are not severely malnourished. The point to be noted that parenteral nutrition is rarely applied to the patient with head and neck cancer because in most of the cases, the lower GI tract is functioning. Now the prognosis comes like cancer cachexia significantly affect the prognosis of the cancer patient, often indicating the advanced disease. Early identification and comprehensive treatment strategy are crucial in managing symptoms and improving quality of the life. Ongoing research aims to better understand the mechanism of cancer cachexia and development more effective treatment. The importance of palliative care integration should also be assessed. Concluding all, cancer cachexia is complex and life-threatening syndrome, require early diagnosis and a multidisciplinary approach. The research is also ongoing for the better treatment. These are the references used for the presentation. Thank you all.